The House Health Policy Committee will come to order. Would the clerk please call the attendance?
Chair Vanderwall.
Present.
Representatives Thompson, Mearman,
Here.
Tisdall,
Here.
Bierlein, DeBoer,
Here.
Preston,
Here.
Schmaltz,
Here.
St. Germain,
Here.
Bonak,
Here.
Frisbee,
Here.
Witset, Carter,
Here.
Whitworth,
Here.
Neely,
Here.
Hoskins,
Here.
Foreman. Mr. Chair, you have 13 members present. You do have a quorum.
Thank you, Madam Clerk. Representative Frisbee moves to adopt the minutes of the April 23 meeting. There being no objection, the motion passes. Today we are going to be hearing a presentation from the Michigan Council of Maternal and Child Health. Next, we will be voting out House Bill 4101 and 4380, as well as taking additional testimony on 4246. Finally, as we finish today, we will be taking up testimony on House Bill 4399. First up, we have a presentation from Amy Zagman with the Michigan Council of Maternal and Child Health. Amy, the floor is yours. We appreciate you being here, and whenever you're ready, you may begin your presentation. Thank you.
Thank you, Mr. Chair. I promise I have not put Representative Frisbee between the two of us to avoid you. I just thought I'd get close to the microphone. So good morning, everyone. Thank you to Representative Vanderwall, Chair Vanderwall, for inviting me to speak with you this morning, and thank you for this time. I'm going to keep my presentation relatively brief in the interest of the other issues on the agenda. I wanted to just share, for those of you who are not familiar with the council, that we've been around for a little over 40 years. We have members who are provide generous support to the council, and our organization was founded by a dedicated group of individuals that believe we must bring together the voices of medical care, community services, and public health to advocate for legislation and appropriations that facilitate the best care delivery when needed, and that we must direct resources towards programs and services that can prevent more costly, in both human and economic terms, outcomes downstream. We're committed to helping give voice to healthcare services and supports, as I mentioned, that help families grow and thrive. Our board is comprised of licensed clinicians and public health professionals, and these are the 2025 policy priorities that group has directed us to work on. They probably, I hope, encompass all the things that you would imagine around maternal and child health. I'm not going to pick a couple from this list and risk not being able to read the whole list to you, but please know that if you're interested in legislation, policy, appropriations that impact maternal and child health, it is likely something that matters deeply to us. We're really grateful for the bipartisan attention that has been spent on many of the issues that we care about. I would highlight behavioral health as well as maternal health over the course of the last few years. We're very grateful that this committee took the time last year to advance a package designed really to help improve maternal health outcomes, and hope that you continue to do so. Bills have recently come over from the Senate that we hope that you will consider on your agenda. As far as healthy births, we still have a lot of work to do, but we should take a moment to celebrate in Michigan. A lot of the sustained work that we've been doing over the last few years with leadership from the administration, with agreement from the legislature, and hard work on the ground has put us in a situation where our infant mortality rate is at the lowest on record, 6.1. That's 6.1% is represented as the number of live births, so that's 6.1 per 1,000 live births. But we know that we can do better, and we know that to keep making progress, most of what we need to do is sustain many of the good things that we're doing. I want to encourage all of you. I've done this before, but I'll do it again. Michigan has a perinatal quality collaborative. Every state has one where we really think about all the things that go into healthy moms, healthy babies. And we also, unlike many other states, have regional perinatal quality collaboratives. We have 9 regional perinatal quality collaboratives. So every one of you has a group of dedicated folks who are pulling together regularly. Many of them meet monthly, and they're talking across community services, public health, hospital systems, other care providers, and looking at regional data to really identify what needs to be done with regard to maternal and infant health outcomes. So I would really encourage you, if you're not familiar with your Regional Perinatal Quality Collaborative, please find them. We've encouraged them to find you, so hopefully maybe that's happened as well. I'm going to skip a couple of these slides in the interest of time, but please know that it's not because we're not interested in all these issues. There certainly are preventable accidents and things that we think can be done around keeping kids safe. I want to focus just for a minute on mental health. The council has been very interested, as I know many of you have, in supporting behavioral health and addressing what has become a crisis really among our adolescents. Much of that is around access to providers, but we also know that there's more we could do to help children at the earliest stages possible with coping skills, making sure that they're self-identifying their needs and reaching out to trusted adults. We know that we can do more as far as access in schools. Obviously, we've worked with the Education Committee, we've worked with the school aid appropriation subcommittees about getting additional resources into schools where kids spend most of their waking hours to make sure that they have access to mental health services where they are. We also know that some children will need more intensive services, and so we definitely support and have spent significant advocacy time encouraging a full continuum of options, is including various settings where we think children can be best served. We're in the midst of a measles outbreak. We're now up to 12 states, so certainly I think it's important that we talk about immunizations. Our membership is deeply committed to making sure that we have immunizations available and that we encourage and educate anyone who is eligible for and interested in receiving immunizations. It goes really beyond that for us. I mean, we are strong believers that there are certain individuals, and some of them are seen by our members in pediatric subspecialty clinics and others, that can't be immunized, right? It's contraindicated for them. The only way those individuals are protected from things like measles is if there's herd immunity. If the rest of us who are healthy enough to receive our immunizations do so on a regular basis and on the schedule provided, we absolutely advocate for things like reimbursement for additional time for families that feel like they want to have additional interaction with their providers to feel that all of their questions have been answered around vaccination. But we are in a precarious situation in Michigan. We had this measles outbreak, and we also know that our rates, especially among our youngest children, have been dropping, and we are now below herd immunity for many vaccine preventable conditions in our state. I want to just touch real briefly on Children's Special Health Care Services. We are on the Advisory Committee for Children's Special Health Care Services. If you're not familiar, Children's Special Health Care Services is available to families with children who have rare or chronic conditions that impact them in a significant way. They are receiving usually subspecialty care at one of our pediatric centers of excellence. 2,700 medical diagnoses and conditions are covered by Children's Special Health Care Services. About 70% of those children are dually enrolled in Medicaid, but for the other families, they're able to access the additional services and supports of this program through fee agreements. It's around 55,000 enrollees. It's primarily children. There are a few conditions where adults continue to be covered by Children's Special Health Care Services, but without these services and supports, many of these families would really struggle. We're always looking to do better, so the things that we've pointed out here that we could do better on, there's recently been a policy around intensive care coordination, and we also know that we could provide these families more respite. I'm going to probably drive home a point that you're not immune to, but all of the national attention around Medicaid has us very concerned. Medicaid is really central to the health of children and certainly contributes to healthy birth outcomes in our state. Medicaid covers over 1 million children in Michigan. Over 40% of our births in Michigan are covered by Medicaid, and it is very concerning to us that you all may be put in a position by federal policy changes where cuts may need to be made to our Medicaid program. We absolutely think there are things that we could do better, but in the climate that we're in right now, what we're most interested in is sustaining the gains that we've made in Medicaid. The last few years, we've been able to add things to the Medicaid program, such as doulas, such as centering pregnancy, things that we know are cost effective and will make a difference in the program. But none of those things can happen if, wholesale changes are made that require us to reduce eligibility and potentially see people uncovered in Michigan. We are finishing up or actually entering phase 2 of a project around birth equity education, and we'll be ready to share that with you all in the fall. We've previously published a series of briefs on things like doulas and breastfeeding, substance use. Many of those things over the course of the last few years, we've been grateful to see move forward, and we're really digging deeper to find out what more we can do. Again, we're happy with 6.1 as our infant mortality rate, happy to see progress made, but we're not happy that that's our end point. And I've left you with some contact information. I believe you have business cards for myself and for Tashina Williams, who's our policy director. She's seated behind me in the green jacket, and we are here. I've kind of rushed through this today in the interest of time, but we're here in town. If you want to talk to us about maternal and child health, we're passionate about it, and we want to work with you on policy legislation and appropriations to help families survive and thrive.
Very good. Thank you, Ms. Zagman. Committee, any questions? Yes, Representative Thompson.
Thank you, Mr. Chair. Thank you so much, Mrs. Zagman, for coming and testifying. Some of the concerns I have is with the increased rate of C-sections, not only for black and brown women, but for white women as well, for across the board here in the state of Michigan. Sure. We know that in 2022, our C-section rate was 33.1%, and now in 2023, it has only risen a small amount, but it's risen to 33.3. So that means there's about 33,000 C-sections to 99,000 births. So the number one reason we are seeing the increase in the C-section rates is women's blood pressure, especially African American and Hispanic women, are at a greater risk for higher blood pressure, for hypertension. And the medication that's administered is Pitocin. I'm going to ask really quick questions, and if we maybe can get through some really quick answers, I apologize.
That's okay.
Does Pitocin, using the medication Pitocin, increase a woman's risk of getting a C-section?
I am not a clinician, so I'm not going to attempt to actually answer your question, but I will say that we agree with you that hypertension and controlling hypertension before you get to the point of potentially being in that situation and potentially having Pitocin exacerbate that condition is critically important.
Absolutely. So Pitocin, the use of Pitocin actually increases a woman's risk of cesarean section by up to 50%. There are other interventions that can be used other than Pitocin. And then a woman that has a C-section, does that increase or decrease her risk of being able to nurse or her likelihood that she would breastfeed?
I think it's common knowledge, right, that it reduces that because not traveling through the natural birthing process likely will not bring the milk down, will result in a delay with regard to initiating breastfeeding. And we know if initiation isn't successful, that
so
you won't
right.
be successful long term.
Women that do have cesareans are up to 25% less likely to nurse because of all of those reasons. And then we know that we have a large number of women in these underserved communities that are utilizing the WIC program. So the U.S. Breastfeeding Committee recently reported that of those women that receive WIC, only 66.1% of them are using formula and not breastfeeding. So if we have underserved low-income families that are exclusively using formula and not breastfeeding, we know that breastfed babies are 50 to 60% less likely to die of SIDS. So my question, ultimately with that whole train of thought is your organization working with the WIC program, and how can the state of Michigan encourage women to breastfeed and come up with policies that are promotive of breastfeeding? Because we can see the direct correlation between hypertension, induction, less likely to breastfeed, less likely to have negative outcomes, hemorrhage after a C-section, infection, et cetera, et cetera.
So absolutely, longstanding proponents of breastfeeding. The Michigan Breastfeeding Network is a member of ours. You asked specifically if we've worked with the WIC program. We have a great relationship with WIC, and some of our members are WIC providers at the local level. I think the issue, WIC has breastfeeding peer counselors. I think they're available. They provide hospital grade pumps for individuals who are insured through Medicaid or others. They may have available to them an electric pump. All of those things are necessary usually to be successful at breastfeeding, because people have to return to work, to school, and we know that we believe that WIC is promoting of breastfeeding. Could they do more? I absolutely think there's always more that could be done to be promoting of breastfeeding, and that education that happens between the WIC counselor and the individual certainly, I think, is a place where we could look to see, if individuals are feeling supported. And so it would be a good question for our WIC agency to find out how often they're interviewing individuals to find out how supported they feel at that person-to-person in context level. I don't know if that answers your question. We're incredibly supportive of breastfeeding. We have fought for things over the years to try to make breastfeeding more accessible.
There are some hurdles that may need to be undertaken, but the correlation is insanely showing the results of how important it is to breastfeed. So thank you so much. I appreciate your testimony.
Thank you.
Thank you, Representative. Any other questions? If not, thank you very much for being here. And we look forward to working with you in this issue. Thank you. Next up, we are going to vote out the PT compact bills. First, we need to adopt the substitute for 4101. And I do have a couple cards that I do want to read real quick. 4101, 4380, not wishing to speak in support. Brian Gilbert, president of APTA of Michigan, not wishing to speak in support of both bills. Denise Hoffman, Michigan Occupational Therapy. Representative Meerman moves to adopt the H1 substitute for House Bill 4101. Clerk, would you please take the roll?
On the motion to adopt the substitute, Chair Vanderwall,
Yes.
Representatives Thompson,
Yes.
Meerman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Yes.
Bonak,
Yes.
Frisbee,
Yes.
Witset,
Yes.
Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 17 yeas, 0 nays, 0 pass. The motion prevails.
The H1 substitute is adopted. Next up, Representative Bierlein moves to report House Bill 4101 with recommendation that the bill be referred to the Committee on Rules. Clerk, will you please take the roll?
On the motion to refer to rules as substitute H1, Chair Vanderwall.
Yes.
Representatives Thompson,
Yes.
Meerman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Yes.
Bonak,
Yes.
Frisbee,
Yes.
Witset,
Yes.
Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 17 yeas, 0 nays, 0 pass. The motion prevails.
House Bill 4101 is referred to the Committee on Rules. Next up, Representative Thompson moves to report House Bill 4380 to the floor with recommendation that the bill then pass. Clerk, would you please take the roll?
On the motion to report, Chair Vanderwall,
Yes.
Representatives Thompson,
Yes.
Mearman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Yes.
Bonak,
Yes.
Frisbee,
Yes.
Witset,
Yes.
Carter,
Yes.
Whitworth,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 17 yeas, 0 nays, 0 pass. The motion prevails.
House Bill 43 is reported with recommendation. Next up, we are going to continue testimony on House Bill 4246. We had a few speakers that were unable to speak last week, and as promised, I wanted to make sure that we heard everybody's voice. First up, we have Doug DeZino, the Chief Nursing Officer for Trinity Health of Michigan. He is joining us via Zoom. And Doug, thank you for being here. Appreciate you coming back again this week. And the testimony table is yours. Take it away.
Good morning. Can I be heard? All right. Good morning, Chairman Vanderwall and members of the House Health Policy Committee. My name is Dr. Doug DeCenzo, and I'm the Regional Chief Nursing Officer representing Trinity Health Michigan. On behalf of Trinity Health Michigan, I thank you for the opportunity to testify today in support of House Bill 4246, legislation that would provide for the state of Michigan to join the Nurse Licensure Compact. Trinity Health Michigan acknowledges Representative Green for reintroducing this legislation. I request that the following points be considered when deciding to support this bill. A Michigan Health and Hospital Association survey found almost 5,000 nurse vacancies in hospitals statewide. Nurse vacancies negatively impact accessibility to care, treatment, and services for all Michiganders. 41 other states and 2 territories have already entered into compacts, resulting in a competitive disadvantage for nursing talent in Michigan. Trinity Health has implemented a virtual connected care model supported by virtual nurses, each with at least 8 years of clinical experience. Virtual nurses caring for hospitalized Michiganders must currently be recruited solely from Michigan, further exhausting the state's nursing talent pool. There are concerns that have been expressed about the competency of nurses from other states compared to Michigan nurses. While Michigan nurses are required to earn 25 hours of continuing education within the 2-year period preceding the date of relicensure, some states do not mandate continuing education. However, meeting these requirements does not ensure competency. For topics like pain and implicit bias, completion may simply involve purchasing published course content and completing a brief self-evaluation. In other words, there is no strong body of evidence to suggest that a nurse licensure compact leads to a decline in patient care quality. Most nurses surveyed in the 2022 Michigan Nurses Study did not believe that the nurse licensure compact would weaken patient protections. In summary, a nurse licensure compact in Michigan would allow nurses to practice more easily, conveniently, and cost-effectively across state lines, more easily redeploy nurses in an emergency, improve access to care for Michiganders, including telehealth and virtual connected care, and provide staffing flexibility by allowing organizations to draw from a wider pool of nurses. Thank you again, Mr. Chairman and committee members, for the opportunity to share Trinity Health Michigan's support of House Bill 4246. I'm happy to answer any questions from committee members.
Doug, thank you for being here. Committee, any questions? Not seeing any questions. I thank you for being willing to come back in today and take time out of your busy schedule, and we look forward to continuing to work on this bill with you and everybody else involved. Thank you.
Thank you.
Next up, we have Sherry Martin wanting to speak in support of the bill. And Sherry, welcome to the Health Policy Committee. Thank you for making the trip back again this week, and we look forward to your testimony. Just hit the little red button by the base of the mic when you're ready, and the testimony table is yours.
It's nice to meet all of you, and it's an honor to be here to speak to each and every one of you. And a special thank you, especially to the people that are on your board that are nurses. I'm here today to speak in favor of the compact licensure, okay? I want to tell you a little bit about myself so that you'll understand. I have the bill here. I've read it word for word numerous times. I've also done some other research as well. I started out in the health field when I was 16, 17 years old, okay? I was a co-op student at my high school, and they taught me at a local hospital all about phlebotomy and how to do EKGs and stuff, and then they taught me how to be a nurse's aide. Now, I did that for a while, and I ended up getting married. My husband was in the Air Force, and he had gone to Vietnam, and he came back, and we moved to New Mexico, and I worked on a med-surg floor there, and I was accepted into a 4-year nursing degree program at the Eastern New Mexico University. Now, we were only there for about a year, and he got orders for England. So obviously my education was interrupted. I got over to England and started doing phlebotomy over there and saw nurses walking around with stripes on their hat, and I said, there's a nursing school around here somewhere. So I found out where that was, and I went to nursing school in England. And that was like a 2-year diploma schooling that counts as an SEN. It's a state enrolled nurse. Then I came back to the States, continued to go to school, and set the boards here because I had to pass the boards in England in order to qualify to set the boards here. Okay? I walked out of my nursing program here in Michigan as a licensed practical nurse. That's what they accepted my training. It was a 2-year full diploma training in England, but they accepted it as a licensed practical nurse here. And out of that training, I walked into a job working my heart's desire, which was neonatal intensive care. Now today, that wouldn't even be possible. That would not even be possible for me. I worked there for years. I felt called to be there by God. And because of the people that you have in places like your M&A and your ANA, your ANCC and everything, they've caused divisions within the nursing field. As an LPN, I'm not even allowed to belong to the Michigan Nurse Association or the American Nurse Association. Okay, I'm used to working in an area of neonatal where we work together as a team. Really didn't matter if you had LPN, RN, 2-year schooling, 3-year schooling, BSN. We worked as a team, and what came first was our patients. That's what came first, and that's why we're here. Because who are the patients? Who are the patients? The patients are all of us. At some time or another, every single one of us is either going to have a family member or we ourselves are going to be a patient. And don't we want that person that's caring for us to be a giver, not a taker? We want givers. We want people. We want nurses that really have that calling on their life. Okay? And I have not always seen that. Most nurses are that type of people, but not all of them. Now, I did not write up a bunch of statistics to give you today, and I did not write up a speech because I want to speak to all of you from my heart. Okay, what is truly on my heart to get through to you why this compact is necessary. Okay? First of all, we have 42 states and territories that have already accepted the compact. Okay? I started 8 to 10 years ago fighting, okay, for this. I would come here to Lansing, to the Capitol, and I would be the only nurse out there carrying a picket sign and trying to bring awareness not only to the compact, but to our issues of nurse-patient ratio, because I felt that every single one of us were standing at a disadvantage of getting good care. Now, I will tell you, next week I'll be 72 years old. I have been doing nursing for a long time. I was still working 3 to 5 12-hour shifts in a row last year. I got sick. I take care of ventilator babies that have a trach, that have a feeding tube in, and I got sick. Even though I'd had the vaccines and everything, I got sick with shingles. Well, the shingles went to my spine, and it went to my brain. And within a short period of time, I had 4 brain bleeds last May 3rd. Now, I was in intensive care, and I also was in the hospital 5 to 6 weeks. And it's taken me a good year to try and recover to get to the point that I am. I ask myself, why did I even survive that? Because all of my doctors seem to think that it's quite a miracle that I'm up and walking and talking and everything. And I think one of the reasons I survived was to come here today to talk to all of you about how bad we need this compact. This compact is not going to decrease the care that a patient would get. That is an individual thing with an individual nurse and how much she cares about her patient, how much she cares about her profession, what kind of a person, what's her integrity, what's her character, okay? That's what that is about. Now, you have here in Michigan a lot of older nurses that maybe they are snowbirds. Maybe they want to work in Michigan 6 months. Maybe they want to go to Florida. That's not me. But what I can tell you is at the time that I was working these 12-hour shifts, I was also taking 5 classes online, nursing classes, to get certificates so that I would be able to work online. There are classes that you can take, there are certificates to do like utilization review, you can do chronic care management, okay, all of these different things that you can do. Now, I could be a Michigan nurse staying in Michigan. The compact is not going to make me leave Michigan. It's not going to make me leave my family or anything else. I was born here, raised here. The only time I've left is when my husband was in the Air Force. Okay, and I came back home, okay? The problem with the compact, what I'm asking this board to do, please, for God's sakes, move into the future. Technology is not going to go away. We have all these other states that have already accepted this compact. We are literally, Michigan's behind. We're one of the only states that have not put it into place. And I am telling you, you need to give the nurses their freedom.
Thank you. I know that we have a couple questions for you. We'll start out with Representative Thompson.
Hi, right here. Thank you so much. Thank you, Mr. Chair. Thank you so much for the passion behind your testimony. I just have one quick question, and I think a lot of people don't realize this. I appreciate you talking about the division between LPNs and RNs and union nurses and non-union nurses. In your career as a licensed practical nurse, can you estimate how many registered nurses you trained?
It would be, I can't even tell you, because I'm going to be honest with you, that especially in neonatal intensive care, we were always short-staffed. I knew what it was to not get a bathroom break, not even have time to eat. I worked a lot of 16-hour shifts.
I don't mean to interrupt you. I know Have you trained RNs as an LPN?
Yes, I have.
All right, thank you
And
so much.
what I want to say to that is that we had a very large turnover. Staffing, nurse-patient ratio is an issue.
Thank you. Any other questions from the committee? Not seeing any. I want to say, number one, thank you for coming back this week and sharing your story and your passion for going out of country to continue your career path. And, of course, want to thank your husband for his service to this great nation. But thank you for being here today.
Thank you very much.
We have a few cards to read in. Not wishing to speak in support of the bill, Shelley Stahl, National Council for State Boards of Nursing. Not wishing to speak in support of the bill, Keith Mentz, Francis Kidney Care. Not wishing to speak in support of the bill, Jarrett Scrope, Mackinac Center. Not wishing to speak in support of the bill, Aaron White, representing himself. Not wishing to speak in support of the bill, Wendy Block, Michigan Chamber. Not wishing to speak in support of the bill, James Johnson, Michigan Association of Counties, Michigan Medical Care Facilities Council. And not wishing to speak opposing the bill, Lisa Vermander, representing herself. Thank you all for being here and testifying and submitting your cards. Next up, we are going to take testimony in House Bill 4399, introduced by Representative Preston. There are a lot of speakers, and as I committed to each and every one of you in the audience today, for those that are online, for those that called in and asked if they could come and testify, I do promise as chair that your voices will be heard, and we will take more testimony next week on this. So understand that if we don't get to everybody today, I apologize, but we want to make sure there's ample time. Joining Representative Preston is Nyala Russell with the Michigan Council of Nurse Practitioners. I welcome both of you to the testimony table. When you're ready to speak, if you can make sure your light is on at the base of your mic, and the testimony table is yours.
Thank you, Chair and members of the committee. I'm here to testify in support of my bill, House Bill 4399, which would remove the requirement for nurse practitioners to contract with a physician in order to provide care under their own license. This bill does not increase the scope of practice for nurse practitioners. It simply codifies the existing regulations around what a nurse practitioner is currently providing to their patients. Michigan is one of only 11 states that limits nurse practitioners to restricted practice authority, requiring nurse practitioners to contract with a physician who delegates their practice authority to the nurse practitioner. This creates unnecessary barriers to entry and restricts desperately needed primary patient care. The Detroit Free Press reported in 2022 that Michigan is projected to be short by over 800 primary care physicians by 2030. We must do better. Healthcare systems are restricted from fully leveraging nurse practitioners in underserved areas like the rural communities of the Upper Peninsula under the current physician contract mandate. Physicians are compensated under these routine contracts. If the physician exits the contract, whether through retirement or relocation, all the nurse practitioners in the practice working under them lose their practice authority and leave their patients without primary care until a new contracting physician can be found. This puts nurse practitioners and especially their patients at risk every time a physician retires or moves. My bill codifies that the Michigan Board of Nursing may grant a specialty certification as a nurse practitioner to someone that has completed the appropriate education, holds a certificate from nationally accredited certification board, and meets any other requirements approved by the Board of Nursing. Under this bill, a nurse practitioner would have the practice authority to perform assessments like physical examinations, diagnose, treat, manage patients, order, perform, supervise, and interpret labs, imaging studies, prescribe medication and non-medication interventions within their specialty, as well as supervise registered nurses, LPNs, and other health professionals deemed appropriate by the board. Under the current law, physicians already delegate prescriptive authority to nurse practitioners for Schedule 2 through 5 medications. This bill changes nothing regarding prescription authority, as our state and rigorous federal safeguards will remain in place as they exist today. This bill leaves prescriptive authority intact for much-needed patient access to life-saving medications. The bill also does not change how nurse practitioners order or interpret diagnostic tests. Procedures like radiology tests will still have a final reading and interpretation with a radiologist. Practically speaking, the tasks performed by a nurse practitioner would not change under this bill. They will continue to diagnose, prescribe, and manage acute chronic conditions based on their education and certification. This is primarily about removing the requirement for a physician contract to delegate authority to nurse practitioners. Nurse practitioners would not be able to open and operate their own practices because that would require an amendment to the Michigan Limited Liability Company Act. We are not opening that act in this bill. This bill is about building additional capacity. It will allow federally qualified health centers, university clinics to stop maintaining supervising physicians for their signature on a piece of paper. That means we will stop the hemorrhage of primary care providers, retain our graduates, and recruit them from other states that have yet to adopt this full scope authority. Eliminating unnecessary physician contracts enable nurse practitioners to deliver timely care to patients who otherwise face long wait times or significant travel burdens. Independent practice ensures nurse practitioners can fully utilize their skills to manage chronic conditions, promote preventive care. Nurse practitioners typically provide care at a lower cost than physicians, reducing healthcare expenses for patients and systems. Over 25 states have granted nurse practitioners full practice authority, demonstrating its success in improving healthcare access and outcomes. 6 more states, not including us, are considering legislation to add full practice authority. Michigan risks falling behind by maintaining our restrictive regulations. This bill is all about building capacity. When it comes to the continued primary care crisis, we know that the status quo is not working. Emergency departments are flooded because of the lack of primary care. Clinics, like urgent care clinics, are unable to provide proper care to patients. Until the patient-provider relationship is reestablished, strains on every aspect of the healthcare system will endure. This state has a long history of obstructionism and bureaucratic barriers when it comes to licensing. We need to get out of our own way and start to think about effective ways to deliver better patient care. I appreciate your time, and I'm happy to answer any questions.
Thank you, Representative. We will have several questions. I'm actually going to ask if the next speaker can speak, and then between the two of you, we can field some of the questions and make sure that we don't double the questions up. And so whenever you're ready, the floor is yours.
Thank you, Chair Vanderwall. Thank you, Representative Preston, and welcome members of the committee. My name is Nyla Russell, and I'm here on behalf of the Michigan Council of Nurse Practitioners. There are over 14,000 nurse practitioners in the state of Michigan. I'm a doctorally prepared family nurse practitioner, and I practice in Traverse City. I'm joined today by the folks in the audience who are wearing green to represent Full Practice Authority. These are nurse practitioners. You may recognize them from your community as your healthcare provider, and they're here to support this bill. Throughout the U.S., there are over 1 billion patient visits with nurse practitioners every year. We're ubiquitous to the healthcare system and an essential provider in Michigan. We are a source of primary care, mental health, and other specialty services. House Bill 4399 seeks to remove the regulatory restrictions that limit nurse practitioners' ability to practice to the level of their education and certification. These restrictions, which require the physician delegation for prescriptive authority of Scheduled 2 through 5 medications, require a contract that limits nurse practitioners' ability to provide care. These restrictions essentially tether nurse practitioners to a physician, but they don't provide any meaningful collaboration. According to physicians' own statements, they don't even need to be in the same room as us, the same practice, the same county, in order to provide the supervision of our practice. Today, we're seeking to codify existing regulations into statute and adopt full practice authority. In doing so, we will codify rules without any expansion to our scope. As a representative for the Michigan Council of Nurse Practitioners, I believe that now is the time for Michigan to join 27 states, DC, and 2 U.S. territories in adopting full practice authority. I was born, raised, and educated in Michigan. I've been married to an active duty service member for 20 years, and during this time, I participated in the healthcare system at the NP level in 4 states, 2 with full practice authority and 2 with restricted practice. What I find most interesting is that my practice doesn't change regarding those laws. Whether it's a full practice authority state or a restricted practice state, what I do every day is exactly the same. I diagnose, treat, prescribe, I manage acute and chronic conditions, I interpret diagnostic tests, and I refer when necessary. We are taught and credentialed to do these things in school, whether the state is full practice authority or restricted. And I'm proud of my husband's 25 years of service because I've been afforded many opportunities as an active duty spouse. But it's challenging to move at the whim of the U.S. government and to adopt to these variable practice standards. When I moved back to Michigan, I couldn't update my DEA license until I obtained a state-controlled drug substance license. I couldn't obtain a state-controlled drug substance license until I had a contract with a physician. I couldn't participate as a Medicaid provider or get credentialed with other insurance companies until this physician contract was identified. All this despite the fact that for the previous 6 years, I practiced under my own license, without a contract, had my own DEA, my own state-controlled drug substance license, and was fully credentialed in the state of Maryland without any incident. You can see the challenges that this poses to my practice. If it weren't for my husband's transfer back to Michigan, I may not have come back. To be honest, although Michigan is my home and I love it, I would prefer to practice in a full practice authority state. Remember, 27 states, DC, and 2 U.S. territories have already recognized full practice authority. Their systems are functioning well. I can attest to it. I was there. It works. Patients have access to safe, high-quality care without unnecessary regulatory burden. None of these states have ever repealed full practice authority because it works. It's time for Michigan to join this effort. This is a healthcare access bill, a workforce development and retention bill, and every person in Michigan is a patient and deserves access to care. I urge you to pass this no-cost legislation that will have immediate impact on the healthcare of Michiganders, and I welcome any questions. Thank you so much for your time.
Thank you, Ms. Russell. I know that we have a question from Representative Schmaltz.
Thank you for being here. Thank you for your testimony, and thank you to your husband for his service. I know when you call nowadays to get an appointment with your primary physician, you usually end up with a nurse practitioner. That happens in most cases now. You talked about the results in other states that have implemented this practice. Can you just talk a little bit more about that? Do you have any statistics? Has it worked really well? I know you touched on that, but do you have anything more?
Yeah, I mean, as I mentioned, 27 states, DC, 2 U.S. territories have been doing this, and some of them since the 90s. So it does work well. The first states to adopt it were states like Oregon, and it was because of the rural health access needs, which we certainly have in Michigan, like in the UP. Maryland adopted it in 2015, and I was fortunate to practice there for 6 years. The physician that I worked with actually only hired nurse practitioners because she knew that we practiced independently and she didn't want to have the rigmarole of overseeing another provider. She didn't need that. She saw the value that we brought to her system. So I think that, statistically, like I said, there's a lot of data that shows that nurse practitioners are more likely to work in rural settings because we typically are able to be educated and go back to our own communities. So it does increase access to care. There's lots of information that, to speak to the quality of the care that we provide, and that there's actually patients who prefer a nurse practitioner sometimes, and that patients should have access to choice of which type of provider they see.
Thank you very much. Any other follow-up, Representative? You're good. Next person, Representative Whitsett.
Thank you for your testimony and thank you for your husband's service and your service because you both are. What are some of the Schedule 2 to 5 drugs that are prescribed?
So Schedule 2 to 5 medications includes things like opioids. It includes benzodiazepines. It includes stimulants, for example. So there's a range of medications. It could be Tylenol with codeine. It can be hydrocodone, Ativan, things like that. But also, think about all of the children who are on stimulants, who have ADHD, who, need those every day to function. I think one of the things that people are really concerned about is that this bill would increase prescribing of those substances, but that's truly not borne out in the data. And we do have guardrails in place in the state of Michigan to prevent any overprescribing of those substances. So those are the types of medications.
Representative Frisbee.
When NPs started in other PA, those levels, we called them physician extenders. And there was a close relationship with physicians and those physician extenders. What's gone differently in the last decade with physicians and oversight? And can you just touch on that for us?
Yeah, I think there's obviously been a huge evolution of practice. We're actually coming up 60 years for the MP role. It was started in 1965 because of Medicare and Medicaid legislation and the recognition that we needed more access to care. So obviously there was a huge evolution of practice, right? When the Public Health Code was written in 1978, NPs weren't even mentioned because we really weren't what we are today. So our education has evolved. Initially, it was kind of like you had a bachelor's degree and you got this post kind of bachelor's education, but it wasn't a degree. Then it became kind of more of a postgraduate certification type of thing, then a master's degree, now doctoral degree for many of us. And the number of clinical hours has increased and it continues to increase. And so, we just have seen an evolution of the role. And I think that that's being recognized by states. Way back in 2006, doesn't seem that long ago, but in 2006, finally, all 50 states recognized prescriptive authority. So there just had to be this evolution as who we were changed because we've only been around for 60 years.
My question was the physician oversight. What has changed in the last decade? I'm a paramedic. Representative Preston is. We're not independent. We've been paramedics. We've expanded our roles, but we have to operate under a physician guidance. So what has changed in your world that now we need to consider heading this direction?
Well, to be realistic, that's been changing for decades, not just in the last 10 years, because there's been states who've had full practice authority since the 90s. So I don't think that there's really been anything that's changed except for the growth of the nurse practitioner role and our standards and what we bring to the system. We still collaborate with physicians. We still refer to physicians. We still work closely with physicians. We're not trying to replace physicians. We're just fulfilling our role in the healthcare system.
If I could jump in a little bit on that one. So we work under medical control, and we have a medical control doc at our hospitals, and they're very integrated in what we do on our scope because we're out in the field, we're in the facility, we're doing all sorts of stuff. And I think, and correct me if I'm wrong, but I think the contractual agreement that occurs between nurse practitioners and whoever that physician is has become more of a routine engagement, different from what you and I experience in what we do, where the doctor is very much a part of treatment. We have to call in for authority to provide certain treatments and or medications. And there's direct oversight when it comes to us. And I think in a lot of ways that's really faded away. And the agreement is just a legacy aspect of their authority because they're doing the job, and they're doing the job without the direct oversight. A lot of these contractual agreements are distant in nature, outside of the facility. And it's totally different. You bring up a great point.
Representative Thompson.
Thank you, Mr. Chair. In your day-to-day practice, is there anything that you can think of that you have to ask a physician that you contract with permission to do?
No, there is not.
Thank you.
Any other questions from the committee? I have a couple, and this pertains to both, but is a lot of us here come from rural communities. We see the struggle to access to care. And I think one of the priorities, and I think everybody in this room realizes that some of the concerns that I have personally had is what can we do to better access to care in our areas that are underserved. Can you touch on what this bill will do for that, and also what has this legislation done in other, you talked a little bit about Oregon, what you've done in Maryland, they all face the same rural situations. Kind of, if you can see what we're trying to finish here and what we want to get done for these communities, and how has this legislation affected these areas that have already implemented this program?
I can tell you by me, it's a total game changer. You know, everything that I've really brought to this committee has been about capacity, building capacity. Seeing, you know, when I worked at Bay Care Hospital in Marinette, we were in the ER about 60% of the time, 911 the rest of the time. So I was able to see both sides of the spectrum, and the amount of overflow that flows into an ER due to the lack of primary care is just mind-blowing. And it's unfortunate. And it's things like this that prevent that capacity from being built, especially in rural Michigan. You know, we need this type of evolution in the healthcare system to shore up primary care so that patients don't end up in the ERs, and that patient-provider continuity continues. There's, you know, when you go to an urgent care clinic, that's the first time that provider has seen you. They don't know you. If you're able to establish a relationship with your primary care provider, and you're able to see them in a timely manner, that cuts down on ER visits, that continues continuity of care. It increases outcomes exponentially, and it's good for the system all the way around. These artificial barriers that we have, quite frankly, they drive me crazy. We can do better, and like I said before, we have to do better. This is sound legislation, way overdue. It's about time.
I do have one statistic, too, that I can share for Arizona, actually, and the Rural Health Association in Arizona pointed directly to full practice authority for nurse practitioners as contributing to this. So there was 52% growth across the state, with 70% increase to care in rural areas, and specifically because they adopted full practice authority.
Thank you. Representative Bierlein.
Thank you, Mr. Chair. Do you know what the differences would be under your current model, and then what it would look like if this legislation were to pass? What like Medicaid reimbursement rates would be? Does that change?
No, Medicaid reimbursement rates do not change with this. However, Medicaid does require that we have a supervising physician. So if full practice authority were to change or to be adopted, then we wouldn't need to have a supervising physician to be Medicaid participants as providers. So that would be one thing. The other piece is what else would change. So essentially, if you look, and I think it's in the packet, if you look at the existing regulations and you shift it over to the bill language, you see that essentially nothing changes. So what does fall away is that contract that requires the delegation for prescriptive authority for scheduled medications. But what has happened with that delegation is kind of this trickle-down effect for this tethering of our practice to physicians in other ways. And we actually have some folks who will be talking about how that's impacted their practice, but the day-to-day and what we do in diagnosing and prescribing and treating will not change.
With any payer, does it change reimbursement levels?
No, this does not.
How does it lower costs then? I guess that's, if it doesn't change what the reimbursement rate is, how does it lower the cost of the care?
So what it does lower is it lowers practices having to pay that contractual agreement, and by doing so, they're able to hire more providers and then increase access to care. So to his point, if we have more primary care access, it's an impact to the emergency systems, which is much more, more systemic. Yeah.
Thank you. Any other questions from the committee? Yes, Representative Whitsett.
Thank you again. Is there a map available to show where all the NPs are located in Michigan, particularly in the rural and underserved areas?
There is a map of Michigan that shows where NPs practice. I don't believe we put it in the packet, but I can absolutely provide that to all of you.
I would appreciate it. Thank you very much.
Yes.
And then that way I can pass it to everyone.
Absolutely.
We'll thank both of you for being here. We appreciate it, and we look forward to continuing to work with you on this legislation. Next up, wishing to speak in support of the bill, Dr. Ramona Benkert, PhD, ANP, BC, FAANP. Woo! I am telling you, we got them all there, and I appreciate you being here, Doctor. She's a dean and professor at Wayne State University. When you're ready, if you could push the red button at the base, the testimony table is yours.
Well, thank you, Representative Vanderwall, for all that alphabet soup that you included there. That was lots of years of education to get that. So I wanted to thank you all for letting me present today and to the Health Policy Committee. As mentioned, I'm Ramona Benkert. I'm the Dean of the College of Nursing and at Wayne State University, and I'm here today to testify in support of this bill on behalf of the Michigan Association of Colleges of Nursing, which represents 29 Michigan nursing schools that educates nurses at the baccalaureate and at the graduate level. As a nurse practitioner and educator for 38 years, I want to emphasize the importance of graduate nursing education in preparing advanced practice registered nurses, including nurse practitioners. In Michigan, 15 schools offer a graduate program to be for registered nurses to become nurse practitioners, with over 2,600 students and 1,000 advanced practice nurses graduating into the workforce every year, with 75 to 100% of them staying in Michigan. Nationally and in Michigan, graduate nursing programs prepare nurse practitioners to care for patients autonomously based on their nursing education and national certification, which requires a 4-year Bachelor of Science in Nursing degree and several years practicing as a registered nurse and experience in a specified area. This foundation education includes coursework in biology, chemistry, and nursing-specific courses like health assessment and pharmacology, as well as clinical experiences in a lot of clinical settings. The bachelor's degree is a generalist preparation for a nurse. But then they go on to work, and they work in a specified area depending on their area of interest. A nurse practitioner's education and curriculum builds on this prior nursing degree with graduate level courses in advanced pathophysiology, advanced pharmacology, and further health assessment. That's required by our accrediting body and our ability to be accredited as a college. They receive specialized in-person training in various clinical settings that are specialized to their area of interest. And this is also required by our certifying and accrediting bodies. And they must hold at least a master's degree, although several nurse practitioners now hold a clinical doctorate. Passing a national certification exam, and that defines, as well as the education, their scope of practice. This education prepares them for a specific specialty, such as pediatrics, and they are not educated to provide care outside of that specialized area or their certified area. It's essential to note that nurse practitioners are not prepared as generalists, healthcare providers. Their education and certification are specific to their specialty area and population and role. For example, a pediatric nurse practitioner is prepared to care for pediatric patients after most likely working as a pediatric nurse for many years in a hospital or a clinic, and they are not prepared to care for adults or geriatrics. Nurse practitioners provide nursing care across clinical settings and in interprofessional teams. We do not prepare our graduates as assistants or extenders of another discipline. Our scope of practice is within nursing, applying nursing knowledge, and providing nursing care. As deans of Michigan's undergraduate and graduate nursing programs, We are committed to preparing nurse practitioner students to meet the state's primary and acute care needs. We will continue to work together to ensure that Michigan has a highly trained health professional workforce, providing high quality, safe, and effective health care to all citizens. And I did want to add, there was a question earlier about the data on safety and quality. There are decades of data supporting the quality and safety of nurse practitioners. Thank you for your opportunity to testify today, and I'm happy to answer any questions you may have. Thank you.
Thank you, Doctor. Committee, any questions? Representative Meerman.
Thank you, Chair Vanderwall. Do you know of any studies out there showing differences between the states that do this and that don't, as far as care or health outcomes?
The primary data that looks at the differences between regulated or restrictive states and those are not have primarily looked at access issues and the number of nurse practitioners that stay within the state or leave the state. I don't recall, and I could look it up. I'm sure there are studies looking at the comparison and the outcomes, but the data that has been research that's been conducted for years has studied nurse practitioners across a variety of settings, both restrictive states and non-restrictive states, and have continued to show outstanding outcomes of care in all of the chronic illnesses as well as acute illnesses. But I can look to see if there's a specific study that.
Thank you.
Mm-hmm.
Other questions? I'll finish up, and then I think we'll, unless another question comes up, we'll move to the next person. But reading through the bill, and there's been some folks that have made some calls to my office, and I just want clarification. Under this bill, it's interpreted or assumed that NPs who work for a hospital system would be able to run their own brick and mortar clinic, but an independent NP would not. Can you answer that question for me, or is that somebody else that would need to do that?
Well, I think it really goes back to what Representative Preston presented, that how one functions and owns a practice is really under the auspices of LLC rules, not related to their certification education. So no, this bill does not change the ability for a nurse practitioner to go out and hang their shingle and do anything like that. That would fall under the LLC regulations.
Great, thank you. Very good. Seeing no other questions, we appreciate that and look forward to working with you on this bill. Thank you.
Thank you.
All right. For sake of time, I can tell that we're not going to get through all the cards at once. So next week we will resume testimony. I want to be fair to both sides. So wishing to speak opposing the bill is Kathleen Westfall, JD, Michigan State Medical Society. Are you here? All right, very good. Thank you for being here. And when you're ready, if you could hit the button at the base of the mic, the testimony table is yours. And I believe then, is this Rose?
Dr. Ramirez, thank you.
Yeah.
Call me Rose, though.
All right, thank you very much. And then we have Dr. Nagapla. Okay, I'm sorry. Well, sometimes, this Dutch guy from the north doesn't do a real good job at pronouncing names, so forgive me. But I want to say thank you for all three of you being here. You will most likely finish out the testimony for today, and I want to make sure you have enough time. So the testimony floor or table is yours, and we look forward to your testimony. Thank you.
Thank you, Chair Vanderwall and committee. My name is Kathleen Westfall. I am a healthcare attorney and partner with the law firm Kerr Russell in Detroit. My healthcare practice is dedicated to legal and regulatory compliance. In addition to serving as counsel to the Michigan State Medical Society, every day I am advising my clients on how they can provide the best care possible in compliance with healthcare laws and regulations. I am there for the normal everyday day-to-day activities when things are going well, and I'm also there when things are not going so well. Indeed, a regular part of my practice is defending health professionals, including physicians and nurse practitioners, against licensing investigations and disciplinary actions by the Bureau of Professional Licensing within LARA. There can be no dispute that physicians and nurse practitioners each play an important role in our healthcare system. And there is no dispute that we have a very real shortage of healthcare providers in our state. On behalf of my clients, I applaud and commend Governor Whitmer and the legislature for their commitment in exploring solutions to reduce the healthcare shortage, minimize burnout, and expand access to care. Unfortunately, House Bill 4399 will not achieve any of that. The bill does nothing to incentivize or to encourage practice in rural or underserved areas. Indeed, like so many other states that have allowed full practice authority, we will likely find that this bill will result in no changes in the areas where nurse practitioners or others are practicing because it does nothing to address why they are not already there in the first place right now. In the other states that purportedly allow full practice authority, I encourage you to look at what those state laws actually say and what they actually require in order to achieve that full practice authority. And then compare that to the requirements of this bill. And very quickly, we will see how actually this bill is a bit extreme. Indeed, unlike many of those 27 states you've been told about, there is no requirement in this bill that nurse practitioners have any minimum patient contact hours under supervision or collaboration before engaging in independent practice and prescribing controlled substances like narcotics and psychotropic medications. While the bill does require nurse practitioners to comply with standards set by the board and their specialty certification, there is no requirement that nurse practitioners actually practice solely within their specialty certification. And you just heard testimony about what education does and does not prepare a nurse practitioner to do. There are no direct limitations on treating and managing patients with complex conditions, and there's no direction to the Board of Nursing on promulgating rules for when a nurse practitioner must consult with or refer a patient to another healthcare professional, or any other requirement to ensure safe clinical practice. Indeed, the law would actually take effect without any of those board rules being in place. The bill provides no clear guidance to the Department of Licensing and Regulatory Affairs as to when a nurse practitioner is engaging in the practice of a nurse practitioner and when they are engaging in the unlicensed practice of medicine. While there may be some inherent overlapping between the scope of practice of various professions, if you review the Public Health Code's definition of the practice of medicine and the practice of osteopathic medicine and surgery, and then review the scope of practice of nurse practitioners under this bill, it's clear the bill goes too far. Additionally, there's no requirement for title transparency so that patients know the credentials of who is treating them. And finally, the bill does not actually address the conflicting provisions under the Limited Liability Company Act or Business Corporation Act, which directly contributes to where nurse practitioners practice. Very recently, this past February, at Governor Whitmer's request, a report was issued by LARA that contained the department's recommendations to protect people and promote business, including providing efficient, effective, and timely services to all Michiganders. The Cutting Red Tape report contained nearly 80 recommendations, including some affecting the scope of practice laws for certain health professions, including physician's assistants and mental health professionals. Notably absent from this report, the department did not recommend independent or expanded scope of practice for nurse practitioners. As the committee considers this bill, while it is nice to think about the idea of the people whom this bill might help, we must give consideration as to who this bill might hurt. You've heard the testimony, or you will hear testimony, about the significant difference in education and training between physicians and nurse practitioners. This cannot be understated. Michiganders deserve access to care, but they also deserve access to quality care by professionals who have the necessary education, training, and experience to render it. And to address Representative Preston's comments, there actually is no statutory requirement for a physician to contract with nurse practitioners except with respect to the prescribing of controlled substances. That's actually a safeguard that's imposed by Medicaid and other health plans. It is not a requirement under the Public Health Code. I implore the committee not to support House Bill 4339 in its current form, and I'm happy to answer any questions.
Thank you very much, Honorable Chair Vanderwall, and esteemed members of the House Committee on Health Policy. I am Rose Ramirez, a medical doctor here in Michigan. I'm a former president of the Michigan State Medical Society, and I'm the proud owner of a small independent family medicine office in the North Grand Rapids area, actually in Belmont, tiny village. I have employed nurse practitioners and physician assistants for many years and value the contributions of my colleagues in care for our patients. Today, I stand deeply concerned about the potential consequences of House Bill 4399 on my patients and all residents of Michigan. While this bill is being presented as a solution to healthcare access issues and rising healthcare costs, it regrettably lacks any concrete measures to address these concerns. For one thing, evidence suggests that granting full practice authority to nurse practitioners does not improve access to care in underserved regions. For instance, in Oregon and Minnesota, underserved areas remain underserved despite legislative changes. Nurse practitioners choose to specialize and serve in the same areas that physicians do. Furthermore, root causes contributing to access and recruitment and retention, such as burdensome regulations, administrative tasks, denials, appeals, overwhelming proportion of Medicaid and Medicare patients with lower reimbursement rates, and persistent staffing shortages do not merely go away by giving independent practice to nurse practitioners. These are systemic issues that need to be addressed in a sustainable, effective manner. Let us be candid about a double standard that has emerged in this debate. No nurse or nurse practitioner would reasonably accept a physician claiming that they could do the job of a nurse without additional education, training, and licensure. Yet this bill promotes the notion that nurse practitioners and physicians are interchangeable, despite the fact that the practice of medicine and the practice of nursing are legally and professionally distinct. I was born and raised here in Michigan, and many years ago, I enrolled in an LPN program at Montcalm Community College. But about halfway through there, I realized, I really always wanted to be a medical doctor. So I changed course, and I worked as a nurse for 4 years, some in Ionia County and some at Sparrow Hospital, to complete my pre-medical studies, and then I went on to graduate from Michigan State University College of Human Medicine. My husband served in the U.S. Navy for 6 years, and so I went to Florida for 6 years with him. He's also a physician. And then we returned back home to our home here in Michigan. We love Michigan. When we replace physician-led healthcare teams with non-physician-led teams, it's the corporations that benefit, and patients bear the brunt. The corporations save money by employing lower-cost providers, but the patients still have the same amount of costs, and a lot of the costs are shifted, and so patients still have high out-of-pocket costs, and so by just granting independent practice nurse practitioners, we're not going to fix that problem. We also know that nurse practitioners, in a side-by-side comparison with physicians in the emergency room, and there's good studies to show this, that the patient stays were extended by 11%, the costs in the emergency department were increased by 7%, and it raised hospitalizations by 30%, preventable hospitalizations. In summary, when compared to physicians, NPs use more resources but achieve worse patient outcomes. And when I come back, and I want to mention, though, that we talk about decades of data. The reality is that we don't have decades of data on a lot of the things like quality outcomes and things between nurse practitioners and physicians and physician assistants, because we didn't separate out the data from the advanced practice professionals until more recently. And so we're now, in the last, I'd say 10 years, we've gained a lot of really good, solid data because we can separate out the work that the nurse practitioners do or the physician assistants do and compare it to the cost of care provided by physicians. So another thing I want to mention is that in 2024, Bloomberg News presented a great series of articles about, they entitled it The Miseducation of America's Nurse Practitioners. When NPs are not well trained, the results can be tragic. Many NPs will, they go to a regular university, they get a good level of training. But there are so many more today that sign up with an online program with a for-profit school. They have very little clinical experience. And the clinical experience that they do get often has to be arranged by them. And it may be in geriatrics, it may be in, even if they're going to be a pediatric nurse practitioner, there's no standardization or regulation around that clinical care that they have to do in their program. And it is minute compared to the hours that a physician has to do in clinical training to get out and practice. When these nurse practitioners come out of these programs and they've got that NP, they can go to practice sometimes independently in Michigan with supervision, but there are documented situations of just tragic results of people that did not get the care they needed because they were cared for at the hands of some of these vastly undertrained nurse practitioners. So when patients entrust their lives to healthcare professionals, it's our unwavering commitment to transparency, ethical conduct, and above all, putting our patients' well-being first that earns and maintains the physician trust. In Michigan, families rely on healthcare teams comprised of individuals with the rigorous training and expertise required to provide appropriate treatment for illnesses and injuries. Please do not approve House Bill 4399 because it holds a grand promise that it ultimately cannot fulfill.
Thank you. Chair Vanderwall and members of the House Health Policy Committee. I'm Dr. Nagapala. I've been practicing in Michigan for over 25 years. I'm the chair for Michigan Academy of Family Physicians. The Michigan Academy of Family Physicians represents over 4,300 family physicians, medicine physicians, residents, and medical students, dedicating to providing physician-led, team-based, patient-centered primary care for all ages. MAFP opposes full practice authority for nurse practitioners in Michigan as defined under House Bill 4399. Our main concern with this legislation is the effect on patient safety and coordination of care. Nurse practitioners and other physician providers are valuable members of our team. However, their education and training are not as extensive or rigorous as physicians. Preserving physician-led team-based care is best for patients. By the time an individual becomes a licensed physician, we would have completed courses in pharmacology, toxicology. As medical students, we usually have 3-month rotations in internal medicine, family medicine, obstetrics and gynecology, pediatrics, and surgery. Students then go on to 3 to 10 years of additional training in residency pertaining to their specialty. In comparison to nurse practitioners, there's no standard of education or training, which puts patients at risk. Some nursing schools have 100% acceptance rate. Open book exams or other direct entry, which means school will accept applicants who do not have a nursing degree. Herzing University allows non-nursing students to enter its Masters of Nursing in Science and Nursing MSN program, where they complete the program in 24 months. Walden University allows their students to complete the MSN in 14 months. South University coursework is entirely online and can be completed in 18 months. 60% of nurse practitioner programs are offered mostly or completely online. Nurse practitioner training, when compared to physician education and training, has virtually no standardization for obtaining practical experience in patient care. The type of patient care experiences nurse practitioners will get vary from student to student, and breadth and depth of clinical experience is not guaranteed at the individual level. This leads to lack of face-to-face interaction with patients and physicians, which greatly impacts the care patients receive. We're weakening professional standards and putting our patient population at Michigan at risk of malpractice and burdensome and costly testing. These bills would allow nurse practitioners to complete their practice hours in family medicine and then go open an independent practice in dermatology, cardiology, or ophthalmology without any additional training or education and without any physician involvement. It's right there in the bill. There's nothing that restricts them from doing this. Additionally, as mentioned before, states that allow nurse practitioners to practice without physician collaboration and supervision have not shown increased access in rural or underserved communities. Data continues to show that nurse practitioners practice in areas where physicians are currently practicing and will not address Michigan's healthcare workforce shortage. Michigan should instead consider supporting and expanding successful programs that provide recruitment and retention, especially in underserved areas. Michigan's MyDocs program, which provides loan repayment to physicians who move to and provide care in underserved areas, is an existing tool we have to ensure care is accessible in all parts of the state. Without a similar mechanism, nurse practitioners will continue to practice in established healthcare areas. Nurse practitioners are a critical part of our healthcare force, especially as they work and serve in physician-led teams. Expanding their scope to give nurse practitioners full practice authority without collaboration and oversight of a licensed physician will put Michiganders at risk and create a costly environment for both patients and the state. Thank you.
Thank you. And I know that we're running tight on time, so I don't think we're going to have time for questions. I'm wondering if any of you can return next week so that we can have questions. I appreciate that. For all those that we weren't able to get to today, hopefully you can return next week. We will give ample time for that. But I want to say thank you for all of you for being here today. No absent members. There being no further business before the committee will stand adjourned.